We are live.
Welcome everyone to this webinar today, and the webinar is titled Symposia on retinal diseases. And we have a very esteemed faculty with us today, and moderators as well as panelists who will take you through the webinar. The keynote speaker is Professor Atul Kumar sir, who is the Chief and Professor of Ophthalmology, Vitreoretina Services, RP Center for Ophthalmic Sciences, AIMS, New Delhi, who has been a sheet anchor for RP Center for last so many years, and under whose leadership RP Center continues to grow. Then we also have Professor Mangat Ram Dogra with us, who's the Director of the Vitreoretina Services at Grewal Eye Institute from Chandigarh. And he's superannuated from the PGI Chandigarh just few months ago. Then Dr. Rajiv Raman, who's the senior consultant in Shankar Nethralaya Chennai, who's going to be the moderator. Professor Edrin Ko, founding partner and senior consultant, retina surgeons, Camden Medical Center from Singapore. And Dr. Anand Rajendran, Chief Retina Vitreous Services, Arvind Eye Hospital from Chennai. Our esteemed panelists are Professor Vaishali Gupta from Department of Ophthalmology, Advanced Eye Center, PGI Chandigarh, heading the Vitreoretina Services, and Colonel Sanjay Mishra, Head of the Department, Armed Force Hospital, RNR, New Delhi. I would request Dr. Rajesh Sinha, who's with me, to please introduce Professor Atul Kumar sir formally, who's going to be our keynote speaker.
A very good evening to all of you, and I would like to thank Professor Namrata Sharma for allowing me to introduce Professor Atul Kumar, who is teacher of both of us. And it's a matter of great honor for me to introduce him in this webinar. He is the chief of RP Center, AIMS, New Delhi, and is also the advisor to the Government of India in ophthalmology and to armed forces as well. He is a Padma Shri awardee, which is the 4th highest civilian award in India, given for services in medicine. The President of India has also conferred Dr. B.C. Roy National Award to him for excellence in field of medicine in the category of eminent medical teacher. The University Grant Commission has recognized his scientific work by giving a Hari Om Ashram Trust Award for role as outstanding social scientist for interaction between science and society. Sir is also a fellow of National Academy of Medical Sciences 2006. The alumni body of his high school too has felicitated him, and very recently in 2017 he has been awarded the Fellowship of Royal College of Surgeons, Edinburgh, and for his furtherance and excellence in vitreoretinal surgical techniques. And during his tenure at RP Center, the center has reached unparalleled heights, and it continues to flourish under the umbrella of his leadership. A great leader, a very good teacher, a surgeon who is next to no one, and a wonderful administrator. Welcome, Professor Atul Kumar, sir, in this webinar.
Thank you, Rajesh. I don't think I deserve all. You introduced me so well.
Thank you, sir. I would now request Professor Atul Kumar sir to give his keynote address on a very important topic, which is, I think, very close to his heart, and that is unmet need in neovascular age-related macular degeneration, Indian perspective.
Thank you, Professor Namrata and Professor Rajesh. I'm indeed indebted to you for having included me in this AIOS webinar, which will have more of an educational as well as an academic outcome, I think, because we are all mostly from institutional background, and I personally am very addicted and fond of academics and teaching, and so I would love to be in such symposiums if you further ever have, which you think I will be meeting up to the standards of that symposium or the webinar, which is under your guidance. So I shall be talking about unmet needs for India for cases of neovascular AMD. Now, there is a, if if you see AMD, it's a leading cause of blindness now as the aging has increased. Even in the COVID era, of course, some people who are old have not been able to survive, but most of our patients over 60, 65 are getting AMD, and it's been seen in even in younger patients. It's just like getting pre-senile cataract. So I'm getting in 50s also patients with neovascular AMD or its variant, the polypoidal choroidal vasculopathy. It's very difficult to differentiate. Of course, we've got a double layer sign, we've got a peak PED, and we've got polyps on ICG imaging, but they have some similarity. Maybe polypoidal choroidal vasculopathy, as Dr. Ko will tell in Singapore. Of course, we were not included in the Far East studies, India, but now with Namrata and Rajesh there, we will probably get included in the PCV studies. I would definitely like to be one part of it. If you go through VRSI, I won't get included, so kindly include me separately. And 10 to 13% of adults you'll see over 65 are affected. There's a global prevalence of about 8.7%. And there is an increase of AMD will be 50% increase by 288 million. So there's a definite increase. All this slide is basically to tell you that two types of AMD: dry, which is actually 85%, but we see very little of it because patients don't have much visual loss. Only when they get into advanced AMD, a dry scar or a like a severe degenerative dead retina in the center, do they come to us with dry. It's the 15% which is critical to us, which comes with very severe rapid fall of vision, which can be very sudden. As today, I got a patient. She was former Professor L.K. Bhutani, the director of AIMS in the 90s. If you remember, his wife suffered a neovascular AMD and came with a bleed today at 1 o'clock. So the bleed has come under the macula, and it's a very dense bleed which is covering the fovea to the superior arcade to the inferior arcade, and probably I'll have to put TPA in the subretinal space, which I told madam about it. And the cardiologist is in attendance. Her BP is high, so she has to be taken care of by the cardiology people first, and then probably we'll do the vitrectomy and the TPA injection subsequently. So these are the kind of problems which we have, the sudden onset division. So this is 90% of the visual loss. Leading cause of vision, 60 years. Prevalence is high in the industrialized country. We are also kind of industrialized. Indian studies underestimate prevalence of AMD because we don't have actual very good data on it. You need a dilated fundus examination, and you have to look for, you might not be able to pick up much on the color picture photograph, just like DR. You may need to do some special tests like OCT and all, which may not be possible in the community. And if you do a RAB survey or something, probably we'll need a handheld OCT to pick up the subretinal fluid. An in-dye study which was done and showed the prevalence of early AMD 1 and 2, which is as similar to a Western population, but grade 3 appear to be lower. All these studies will have fallacies because they're not actual big RAB surveys like DR has been done recently, and that had a 23.7% incidence. So Indian population currently is having a lot of AMD. We can do hospital-based tertiary level surveys, but that would only mean patients who come to the big hospitals. So it's important that we should have very trained personnel, not only for DR, but also what AMD looks like. So we have to have inexplained lipids, inexplained hemorrhages, inexplained fluid, and subretinal elevation of macula. If you have unexplained in that age group, over 55, 60, then you better think in terms of AMD, and the necessary investigations should be carried out. So the next but it's important to have these basic innovations, OCT, FFA. If ICG is possible, yes, FAF, of course, is very, very, very important. So you have to buy your equipment and then go to a retina specialist for visual gain after cataract surgery. Incidentally, if your dense cataract comes, you can't do the OCT also. Some of these patients may have AMD at the back. And there's a lack of awareness about public and ophthalmologists about AMD. They have more about diabetic retinopathy. So the mimickers of AMD, which can be MACTEL, type 2, BPC, which I just mentioned, it's in a big way in our country. Most of the cases I see in RP center, my field is confined to RP center only. And so I see a whole lot of, I see a whole lot of polypoidal choroidal vasculopathy at our center. And even today also in my OPD, I found at least 2-3 cases, and they may not have the classical polyps, but they definitely have a double layer sign, and they have a thumb-like PED. So all these things are pointers that the patient is having a variant, whether it's some genetic, uh, difference between the Western neovascular AMD or the Far East. Like India would be part of the Far East, so we are having similar to what Japan, China, and Singapore are having. So we get RAP, which is not so common, very uncommon. We get PEHCR, especially in wide field imaging under the Optos, and we don't see much of it. AOFPD or adult onset foveal vitelliform dystrophy is seen, not so uncommon, and we do mistake it for neovascular AMD, and we give anti-VEGFs. So this is a case of MACTEL, which we see the commonest among all those mimickers, and this is usually a beaten appearance with some pigmentation, and sometimes this capillaries are going at right angles. The severe macular degeneration, a cavitation, and a CNVM can develop very often. MACTEL often develops a secondary CNVM. This is the way we see it, and uh, when we see this CNVM, then we just, I think two OPDs back, we had a case, so we gave the anti-VEGF, telling the patient, of course, that the primary visual loss will not be, but the additional visual loss which has occurred recently will be taken care of. Then this is adult foveal vitelliform dystrophy, vitelliform deposits under the retina. They look like as if there's a neovascular membrane and there's some fluid over there, but actually it's not that story. It's vitelliform deposit. It's like you have Best's. Best is also Best is also a disease where you have vitelliform deposits. So choroidal osteoma is something else which is, looks like a osseous transformation of the choroid, and this may be mimic something like a somebody who's not seen many neovascular AMD, especially for the learning residents. It's very good to know the differential diagnosis, and so it's important for them also to see these webinars, which are teaching webinars, and we would see that sometimes even a CNVM can develop in a case of choroidal osteoma also, the degenerative conditions also. Now, in the first line management of anti-VEGF era, the problem is that we don't know which injection to give. So that's an unmet need. The first thing I told you was that mimickers. So we've got to know what exactly neovascular AMD looks like. Second is how to treat. Should we give monthly standard monthly injections? Should we treat and extend? That means extend every 2 weeks after the first 3 injections loading dose, or should we treat and observe and treat as and when required? So PRN dosing as and when needed. That means when the fluid starts appearing again, then you inject. Or you give fixed monthly injection, or we treat, extend 2 weeks. So till now, we haven't been able to kind of zoom in on which particular one entity is very far ahead. We just feel everybody's following his own regimen, and that's perfectly correct. Sometimes in the same OPD, I convert from one patient who's receiving PRN dosing to another patient who's receiving treat and extend. So it's basically how we do, and what would be the final outcome? We don't know. It's unmet need. The cost effectiveness also varies. Bevacizumab is slightly inferior to ranibizumab, but there are problems, problems of bevacizumab, that they can be, ranibizumab is not so cost effective as bevacizumab, and it's actually ranibizumab is more costly, but it has definitely superior gain in diabetic patients as well as neovascular AMD patients as compared to bevacizumab. But one second. Okay, anyway, there's the thing is, for bevacizumab, there's one small drawback, not small drawback, that it can lead to, because we are counting what we'll have is single dose bevacizumab. That would be the ideal thing. If the DGCI, I think Professor Vaishali was also there in that meeting held 3-4 years back. The DGCI barely gave us permission to use bevacizumab, but the thing is, we are right now having multi-dose vials. Those multi-dose vials, you have to pull out injections and then give it. And those vials can be, 2 vials can be taken for fungal and bacterial, but all has a risk. And because those vials have to be used, they have to be kept in a sterile tray or a container and used within 24 to 48 hours. But the leftover can sometimes be accidentally used, or there can be contamination of the vial. So that is known. These contamination of the vials are well known, and hence bevacizumab is not a preferred drug to give in Indian conditions, because we are talking about Indian conditions right now. We don't have single dose, which would be the ideal single dose bevacizumab. So, but you have Razumab, but that's a biosimilar. So a lot of people use Razumab. Ranibizumab, on the other hand, is a single dose, and even Eylea or aflibercept are single dose. Now, issues, what are the issues with anti-VEGF in our country? Compliance, frequent follow-up, monthly, near monthly, or how often do we follow up? Short duration of the effect. We've seen effect wearing off before 1 month. Sometimes the effect stays on. So it's varying, but it's shorter duration. So the patient has to come back again and again. Like every month, he has to report back. Even if it's aflibercept, often the patient has to come back in about 4 to 6 weeks latest. Because sometimes the neovascular AMD patients or a PCV patient, they can bleed also, especially the PCV patients. I've personally had patients in the COVID period. One patient who was a writer who bled in one eye, despite the fact that we were giving him the standard 4 to 6 week follow-up. We were giving him the fixed follow-ups. And 30% lose vision because by repeated injections, we actually cause a scar or a fibrosis in the macula. And the patient says, my central vision is gone. And so finally, it's low vision aids. Otherwise, receiving anti-VEGF, the patient is unhappy, but we can't do anything. The scar does form, the vascular response may be there, but the scar tissue formation is quite high. So we have this is a major unmet need. If you have less vision, the quality of life goes down. That's what's happening. The risk of infection also stays. You may cause a cataract because the needle tracks instead of pointing a needle towards the vitreous, you actually give it a little more anteriorly. So the lenses are swollen also, and they can literally enter the posterior, cause a huge rent in the posterior capsule and enter the substance of the lens. And then the patient needs to get a surgery for cataract. The cataract surgeon say 4 to 6 weeks later, because I don't do cataract surgery and many of my colleagues don't do. But I'll say to Namrata, please do it. She said 4 to 6 weeks later. Rajesh, please do it. No, 4 to 6 weeks later. Let that wound, which is causing the cataract, heal. And thromboembolic adverse events, you all know, they do occur. Though we may say that it's very safe, I always give it. I have the biggest VRSI surgeon here. The VRSI boasts like that. No, but it happens. It happens. You can't believe anybody. I've seen it myself happening in my own cases after a week, 10 days. So the burden to the patient, these repeated injections, economic burden, the social burden, traveling, all that stuff. He wants to discontinue. He gets into kind of a depression as they're getting into depression due to the COVID era. Now there's another new anti-VEGF which is now coming, which is a little very interestingly very longer acting, and they offer extended VEGF inhibition. It's also known as Beovu or Beobu. So you can pronounce it as you feel like, and it's a humanized single chain. Instead of a double chain, it's a single chain antibody fragment. It inhibits all isoforms of VEGF-A. So it's not VEGF A 170 or 180 isoform, it's entire isoforms. So molecular weight is very tiny, so it enters the retina very quickly. It's even smaller molecule than the ranibizumab. Ranibizumab is about 48 kilodaltons. This is 26 kilodaltons. So it's a tiny fragment. We want the fragment to enter the retina and come into the subretinal space and act on the neovascular membrane effectively and for a longer duration. It stays in the body also for a long time. So there's 3 monthly dosing. So Hawk and Harrier, the main studies which showed that Brolucizumab was non-inferior to aflibercept, which was a gold standard in the form of that aflibercept was being thought as the best drug intravitreal injection for anti-VEGF for neovascular AMD or so Brolucizumab, we can't do everything Western all the time, so it's important. Brolucizumab can be given as 12 monthly, that is 12 weekly, that is 3 monthly, or a 2 monthly, bi-monthly, or a tri-monthly dosing. And that's what they showed, that the outcome in this Hawk and Harrier was very interesting. It was a potent drying agent. But there have been some reports from American Society of Retina Specialists of inflammation following Brolucizumab administration. In addition to cases of mild to moderate intraocular inflammation, which was about 4%, 14 cases had occlusive vasculitis. So that was something which was something to look up to. And since then, there has been though of course it's FDA approved, but still we'll have to be under a little caution. And besides this, there can be other longer acting delivery agents because patients don't, the burden on them. Also the COVID period, they don't want to come back again and again to the hospital for injections and expose them to infections and all that. We would like to give longer injections so that they can stay away from us. But they will be costly also. The Brolucizumab will also be costly. I think, I don't know the cost, but it's definitely going to be more than PDT maybe, or somewhere around PDT, or maybe more than PDT. It's costing around 60,000. So how many patients would afford that? Because many patients in our place just afford Avastin. So sustained delivery preparation, this has, PDS. It's like a port delivery system that, just like you had the ganciclovir intraocular device for CMV retinitis. So same way, there's a biodegradable, non-biodegradable, stitch it to the sclera and keep the port there, and which can be refilled. It's in the office. You refill it, just go to the office, the hospital. The office is USA, but in India, it's the hospital and the OT. We refill it in our OR. But how much we'll get to know this ladder studies on. If it's safe, then probably it can be an alternative. The sustained drug delivery. The wound has to be, of course, kept very clean, and you'll have to take some antibody drops. Some newer novel approaches, which I feel have great importance. And Povista didn't work. It was supposed to be, very effective. It's a bimanual to a twin pronged action. And Faricimab has now come in, and Faricimab is actually anti-angiogenic. It inhibits the angiogenesis through Ang2 inhibition, and it is anti-VEGF. So it's actually combining the two anti-angiogenic effect and the anti-VEGF effect. And Faricimab may be a drug of the future. Only time will tell us. It's a single molecule, two targets. Two targets mean the anti-Ang and anti-VEGF. By maybe combining the two, we may get less fibrosis, and that fibrosis, if it reduces, scar formation reduces, a big boon, and it'll be heaven for the retina specialists. Gene therapy may come in, that you have subretinal delivery of some modified genes, or intravitreal delivery. So we'll have some fine needles. We do vitrectomy. The retina surgeon does the vitrectomy and puts the subretinal gene, which is going to inhibit the fibrovascular proliferation, which is occurring in the subretinal space. So it's really exciting. Targeted immunotherapy also to kill the cells which are responsible for this new vascular membranes. Stem cell therapy is there, but I don't think it's worked. We've done some work at RP Center for dry AMD. It didn't show much of improvement. So wet AMD, because the neovascularization, I don't know how far it's going to inhibit the new vessels. So Faricimab and these new gene therapies would definitely have a role. And these unmet needs would be probably met. How much I can't say, but to some extent. So what present it happens is the neovascular AMD converts to this scar. This is what we don't want. The PCV is something I'm going to tell you towards the end, that this is a big problem which we have in our country, and it's a variant of neovascular AMD. It has more chances of bleeding, and it is less effective with anti-VEGF. So we have to usually resort to very strong anti-VEGFs like Eylea or ranibizumab. And what you get is aneurysmal dilatations in the outer branching network of the neovascular network, the polyps. And the choroids are thickened. That's why it's called pachychoroid spectrum. And the PDs are tiny and thumb-like. They go like sharp peak PDs. There's often maybe absence of drusen, and you may have a double layer sign where the fibrovascular proliferation occurs, the branching vascular network, the BVN. It has an Asian ancestry. It's not reported much in the West, and we see a lot in India. At least we see it at our center. I can't comment on any other society or a center. And I see it, of course, from ages ranging from 30 to 40 to going up to 60 to 70. Even the old age patients, very old patients of neovascular, we see we are continuing with that. So it's some kind of variant, but it's because the findings are totally different. So these are so many collection of pictures which I have of various imaging modalities. This is a branching vascular network, and these are the polyps. I have tons, so I just bought some, and this is a PED, like a thing, thumb-like PED, which is sharp pointed, and this double layer sign over here because of branching vascular network. And this is the branching vascular network, new vessels which are there. This is one patient, and this is another patient with a polyp hemorrhage around it. This is a polyp on ICG imaging. And this ICG actually should be done with the fluorescein angiography. And for that, you need the spectralis. So if you don't have it, then you should get it done from somewhere. And I would recommend that ICG should be given importance whenever a patient with suspected unexplained hemorrhages in the macula, exudates come in the macula, and a patient has drop of vision and maybe having history of central serous choroidopathy. In such patients, of course, OCTA would be definitely required, but in the baseline and maybe 3-4 monthly follow-up, the ICG would be required. We should look for these polyps, because if the polyps are there, there's a higher chance of a bleed. That's what I think. So when I have these patients, then sometimes we have to give more potent anti-VEGF agents. And I sometimes have to resort to reduced fluence or half fluence PDT for such patients. So we see a patient here who's probably had CSR-like lesion before, and now he's developed some hemorrhagic, hyperfluorescent lesion on FA. On ICG, on the same patient, you can see the polyp over here, and the sharp PD corresponds to actually the polyps. The polyps grow here on the inside surface of the PD, and this is the branching vascular network, which is actually like a double layering of the Brooks membrane, or that's what they say, and they say the vessels grow under it. So branching vascular network with the polyps, with the sharp PD, with subretinal fluid is all classic with absence of brucin, is classic of a branching polypoidal choroidal vascular. This is a patient who received the injection 3 monthly loading doses as we give. At RP center, we give monthly loading doses 3, and then we see the patient's response. If it's good, often it's good. We tell him to hang on. We give him a treat and extend policy. So for PCV, so I think probably we need to write on this. Anti-VEGF and PCV, every study we know, we combine the two with the ranibizumab and PDT. PDT is one area where I feel PDT has a role in PCV, because PDT has a role in CSC. So CSC works, amazing results of CSC patients, chronic CSC patients with PDT, reduced fluence, not full fluence. And today I had a case of hemangioma, so I recommended him. It come from Ajmer, so I recommended him full fluence double dose. But full fluence you reserve for hemangioma. Center, various societies and centers may think differently, but I'd like to give double dose, like I told that man. But in PCV, I'll give reduced fluence, because there's a choroidal element of choroidal vascular ischemia, and patient may lose vision. I've seen some of patients, 1 or 2 patients who had poor vision gain after giving full fluence. So we, since time immemorial, 2-3 years, we've stopped giving full fluence, and it causes regression of polyps. I think if it's got a chronic PCV, it's good to take up for PDT, because this chronic, you can't keep injecting, it may be causing more scarring. So when you cause more scarring, there's more problems. The Planet study improved one, or just want to do something else. They use aflibercept instead of ranibizumab. So actually, we've been basically, we've got two choices right now. We've got ranibizumab, aflibercept, and of course, we've got not 3 choices. We have Brolucizumab also. It improves visual acuity in PC patients without the need for PDT. And the basic show aflibercept was very effective. We didn't need PDT. I think PDT is required. When the patient gets very chronic, he's taken 8 or 10 injections. There's still presence of subretinal fluid, and Octa shows new vessels. I'm giving a lot of importance to Octa nowadays for follow-up of neovascular AMD patients, and follow-up of idiopathic CNV patients, for follow-up of PCV patients. I've seen patients even with no fluid, but the presence of new vessels on Octa, they bleed. I saw 2 patients in the last 6 months, and I am an active working ophthalmologist right now at RP Center. I've seen 2 patients who didn't have fluid, and I'd like to ask Professor Vishali's opinion, who had new vessels on the Octa, but had no subretinal fluid, bled. So what I'm trying to say is that, is it that the subretinal fluid may or may not be there, just the Octa? What kind of extra study can we do, imaging study can be done to know that which patient is a potent bleeder, future bleeder? So that's what we want to do. Everest 2 was also the superiority of the combination over ranibizumab monotherapy. And with both ranibizumab and PDT complementing, they found lesser injection. So modified injection, if you get a bleeding, what I do in the last 1 minute, I'm going to tell you that we give TPA, like today, LK Botani, our former director's wife has come. So we give recombinant TPA with bevacizumab and air. And this is the blood which is collected in a PCV eye. And so you see, the blood may be there, but as long as the fovea is involved, you got to do it. It may not be so much, but we get sometimes massive bleeds also going into the arcade to arcade. So if you don't get it even till the arcade to arcade, as long as the fovea is involved and it's an elevated blood, It's not a thin layer of blood. If it's a thin layer of blood, you see how elevated it is. There's PED over here. So the IOCT tells me exactly where to put the needle. This is the IOCT device, which is there on the eyes. So I use this 41 gauge translocation needle, go close to the disc and inject the recombinant TPA, the Vastin. Some blood does come out, the subretinal blood, and I inject air. So this is the technique I've been using for the last 2 years. We got a couple of publications on it because many people are already doing it, and so such publication. But we have 2-3 publications. We are writing another one, which is going to be a little better in the sense that we're going to tell a few modifications we've done in the injection, and that probably will help. So this is the kind of picture, and I can tell you the miracle is the next day morning there's no blood in the macula. The blood is lying at the bottom, the subretinal space. So this is something we've done a lot, and we've got. I mean, I've done a lot, and I've got about 2 years experience at RP Center. RP Center has been like a mother god to me, and all through my MD, and my residency, and my senior residency, my faculty, this place has been sheltering me from all kinds of problems, and I keep doing my work. That's what I like to. And the unmet needs from patient's perspective is that this high burden transportation causes issues, not so much in India, but there are. Of course, in the West it is. But why should we talk of the West? It's time consuming that now with the COVID period, you'll have to first get few patients, you'll have to have a triaging, the patients who are more serious. Like a neovascular MD, yes, like this symposium or webinar. I'd rather call it a symposium, it's teaching. So we'd rather we'll call a neovascular MD or PCV case, then we give him antibiotics, tell him to change clothes completely, wear a mask, and his mask, he goes in the you also identify where all your this thing full PP is required, a full gown, mask, cap, and make sure the injection is given in a most highly sterile condition. We give sodium hypochlorite fogging, and we also do bacillocid spray of all our OT areas as well as non-OT areas every 4 hourly. So with the COVID era, we have been very, very careful because not only the infection, but the COVID infection also is some patients discontinue because the travel is too long. It's of course economic reasons also when it comes too long. So maybe I'm sure doctors are present close by who can give the injection. They don't need to come all the way to large cities. Dissatisfaction with the benefits because as the vessels of new vessels mature, they don't respond to anti-VEGF. That was the reason why they use that Fovista. Fovista would strip the endothelium of its the complete blood vessel. Only the bare endothelium was left. If the bare endothelium is left of the new vessels, only then the anti-VEGF acts best. So anti-VEGF acts best in the first 3 injections. Afterwards, if it's there, it's going to act, the vessels will mature. Then only what will act is probably the PDT. So sometimes you're fooling ourselves. We don't know how much, at what stage we're going to start fooling the patient and ourselves. But that's the only way we have such a major unmet need. The dissatisfaction with the surgeon and with the patient, and the burden of follow-up travel. It's not easy to come to a hospital or a center and keep sitting there for hours and then getting a turn and then going back. Today I was asking one of my patients, how long does it take to get back to work after an anti-VEGF injection? He's about 25. He says 1 week. After the injection, it takes you 1 week to literally feel that you are back to normal. So it's 1 week gone. It's working hours, number of working hours. The patient lives are preoccupied by frequent clinic visits. So we need longer acting, safer, less travel, less COVID. It should not be that we have to. And this is the low wage aid clinic in the retina unit which we have. It's not the main RP center retina unit. This is which I have it in my area, in my retinal lab area, and here we do all kinds of rehabilitation, low vision aids. And often these patients in the end require this. So this is also an unmet need which I feel needs to be developed further, and some symposium where we get these people also on to tell us what kind of visual aids can we give to the patient with neovascular AMD and central visual loss. I would request Professor Namrata and Professor Rajesh, who are coordinating this symposium, very nice symposium, and thank you very much for having thought of including me, because thank you very much.
Thank you, sir, for that excellent overview and for insights into ARMD. And I'm sure it was so well and comprehensively covered. Even I'm not a retina person, but I could also understand everything.
We all
So
learned from the same institution.
yes, sir. So even I could follow. It was so interesting. We were all glued to the presentation. So there are
I
a
love
few
teaching.
questions. If anybody of the panelists would want to ask before I ask the questions which have come on the panel here.
You can go ahead, Namrata.
Okay. So there's a question which says that expert opinion regarding use of Zell trap for ARMD. So what
Is-
and which consent to be taken for off-label use of the anti-VEGFs, and how to counsel the patients when they follow up for years and they are still their vision is deteriorating.
See, Zaltrap is an intravenous form of Zaltrap is basically, you give it intravenous. I don't think it's going to be of great use. Ziv Altra, Zal, Ziv Zaltrap, you can give intravitreal, but see, we already have a preparation. You already have aflibercept. The DCGI has not approved Ziv as aflibercept. And Zaltrap is the intravenous form, and Ziv aflibercept is the intravitreal form. This is basically a alternative. This is the original Avastin. Like the original Avastin is the original molecule, and aflibercept is the modified molecule. They're same family, brother sister. But aflibercept is FDA approved, DCGI approved. All over the world, it's European CE approved. But Zaltrap is not approved. And if you give it, you will land up in major problems. You may even be hauled up and given the worst sentence. So I would request not to please use a drug which is already available to you and should not be used. Avastin we use off-label because it's approved by DCGI for off-label use. We had a drug alert in 2016 due to some endophthalmitis, and therefore we went to DCGI because we had no substitute to Avastin. We wanted Avastin for economic effect of it, and it's also cheaper, and okay, it was also it's very potent. So we went to DCGI and we got the off-label approval. But we have to get a consent. This consent has been circulated by AIOS already. I was one of the members, but the VRSI won't agree to that I was a member. I was one of the members of the group which studied which laid down the guidelines for VRSI. Now you have the boss here from VRSI, General Secretary. He can tell you more on this. If you want to say anything.
Yeah, absolutely. I think Dr. Atul sir, he's hit it on the head. I mean, we kind of did well with Avastin done, and Dr. Atul and an eminent panel from VRSI. I mean, did a
Yeah, there were three
job.
others. Even Rohit Saxena was there, and VRSI this thing. Ajay Roda was there.
Yeah. So I think that was a great humanitarian service for VRSI and the retina community as such. With respect to Zaltrap specifically and aflibercept, individual experience is very minimal. I know there are friends from LV Prasad who have done it and even made small publications, but it's not something we would like to openly, definitively recommend straight away from a panel here. So the experience overall is limited. It does work, but the experience is more anecdotal than level 1 or level 2.
It's not DCGI approved.
Exactly.
If you give it, you'll be in major problems.
Correct.
Avastin you can give with the DCGI has approved it for off-label.
Yes.
And
even we shouldn't give a yes, ma'am.
Even from our personal experience, from our personal experience, once there is a problem, the patients just become very different. They say, you should have given us a choice. You should have told us more expensive drugs available. How do you know we could not afford it? So never ever, touch these things. Yeah.
The other biggest problem is that unlike Avastin, Zaltrap is even not approved for cancer in India.
Absolutely.
So DCGI is not, so it is not even commonly used. It is not used by the cancer specialists. They also get it from abroad. And using a drug which is not even approved for a cancer for eye, definitely out of question. I agree.
There's another question, role of end-phase OCT in AMD.
End-phase OCT can give you some information, but all these OCTAs are on fast only. So end-phase OCT, Professor Vishali, would you like to say something?
Yeah, I would do NFAS OCT along with OCT angio if you really want to see the signal strength and want to rule out any artificial defects, because as Professor Atul beautifully put about angio OCT, and there is a new study now, Avatar study by the Cleveland Clinic group, where they said it's very difficult to distinguish between the active and inactive CNVM on OCT angio. However, if you already have the patient who is on follow-up and you are doing OCT angio, you could monitor the density. And if you feel the density is changing or increasing, that could be the subtle sign of activity on OCT angio. This is answer to Professor Atul's question actually. But NFAS, I will always do along with angio OCT to look at the artifactual strength and the clarity of the media and everything. Per se, just doing NFAS without B scan, without your pictures, without OCT angio, really does not give you a holistic picture.
I think with this, we'll move on to the next talk. The next talk is to be given by Professor Vishali Gupta, and she's going to be talking on importance of anatomical outcome in AMD, NAMD.
Thank you, Namrata, Rajesh, and thank you, AIOS, for your kind invitation. It's indeed honor for me to speak after Professor Atul Kumar. Like, I was just a first-year resident and I have been looking up to him all these years. It's truly, truly an honor. So the topic that has been given to me is what is the importance of anatomical outcomes in neovascular AMD. So let's look at what anatomical outcomes we generally look at. We look at retinal thickness because we are looking at the evidence of fluid. Shrem, to be very honest, we do not really look in our day-to-day practice, but we do look at intraretinal or subretinal hemorrhage, as Professor Atul mentioned about the lady recently with hemorrhage. And earlier, especially in before OCT era, we used to rely a lot and lots on fluorescein, which honestly we are not doing anymore. So these are the different pictures that we can see on OCT. We can have the fluid intraretinal, we can have subretinal, and this is kind of Shrem. And you may have a fluid around Shrem, and there is fluid behind the RPE, or you can have a large subretinal hemorrhage. Now, where does this knowledge that fluid has become so important in our lives comes from? This actually comes right from the era of CAT, and then it goes on and on. Most of the studies, multicentric trials that have been done on AMD have actually took fluid as a very important marker of response to therapy, of disease getting reactivated, and the reason for retreating the patient, because as mentioned again by Professor Atul, we are honestly not treating our patient every 1 monthly after we have given 3 initial loading doses. After that, most of the time we have a tendency either to extend the treatment or to move on to PRN. And the way we work is we do the OCT. If we see the fluid, we just inject. And we don't do fluoresceins anymore. And interestingly, these days, especially AMD, if you actually are doing the fundus examination, that is just a courtesy to the patient, because it all boils down to just looking fluid on OCT. That important is the fluid. So most of the studies like CAT and all actually use time domain OCT, which was low resolution. There was no image averaging, and they were using radial scans. However, the latest trials have used spectral domain OCT, and this definitely gives much more information on the fluid than the previous one. Now let's see what different societies say. Retina RCO, but I will just restrict myself to American Academy, which says that OCT should be used to determine the need for retreatment, which means you see the fluid on OCT, you retreat. Now, does this fluid correlate with visual acuity? The study from the CAT and View 1 and View 2 did not find that complete drying actually means a very good visual acuity. But what is not shown in these slides is that if your fovea is not completely dry, it has a tendency to come back and your vision may go down the months or weeks or years. Now, there are a lot of fluids. There are a lot of kind of membranes. There could be peripapillary membrane. There could be just a SRF drape sitting next to PD. There could be an outer retinal tubulation, and there could be a scar with overlying fluid. Is all fluid created equal? We do not have answer coming as per the etiology, but we do have an answer to this particular question, that should we consider these fluid differently? Now let's see what are the different types of fluid we are talking about. We are talking about the fluid here, number 1, which represents the fluid which is under the neurosensory retina, that is the subretinal fluid, or under the RPE, which is the sub-RPE fluid. Or it could actually be, you could see intraretinal fluid. So these are the, intraretinal is the fluid which is within the retina. So if we look at the sequence of the events, all retinal fluid is considered a disease state, and you have to take care of the fluid irrespective of its location if you want to prevent irreversible vision loss, which means destruction of your photoreceptors. Now, what is the relevance of the fluid? The fluid is important when we diagnose, when we decide to treat, the interval, and finally, of course, the visual outcome. Let's see what different trials talk about the fluid. If we go to the Sailor and Harbor trials, they say the detection of the retinal fluid on SDOCT actually results in treatment and better outcome. Makes sense. You see fluid, you don't let it stay there, you treat it, you are going to have better outcome. Now let's take each category of fluid separately. So coming first to the intraretinal fluid. And intraretinal fluid is the bad guy of all the fluids. It is the fluid that forms cysts within the retina. If it is present at baseline, it means the visual outcome is going to be poorer. If it persists or if it reappears during the treatment, it again means bad news. The outcome is going to be poorer. Now, there is a beautiful study on post hoc analysis of View 1 and View 2, which indicates that the presence of intraretinal fluid, if it is present at baseline, it means your vision is not going to be much improved. Again, there is a secondary analysis of CAT study which says if intraretinal fluid is persistent, that is associated with poor visual outcome during anti-VEGF treatment. Excite study also, the post hoc analysis shows that if during the follow-up of these patients you have new intraretinal cysts that come after you have given the loading doses, it means it's a bad news again, because these are the patients in whom visual acuity is going to decline. So intraretinal fluid all across the trials, whether it is present at baseline or during the follow-up, is going to have a poorer visual outcome. Now we think of the subretinal fluid, like you have a fluid under the retina. So some studies indeed showed that if you have the SRF at baseline, or even if you have a residual SRF after you have treated the patient, actually it leads to the better or stable visual outcome, meaning some fluid, the subretinal fluid, may be actually good. However, there are other data which suggest that if this SRF recurs during the maintenance phase, it again means it could have a poorer visual outcome. So it's a catch-22 kind of a situation. So let's see what the trials have indicated. The secondary analysis of the VIEW study did a sub-hoc analysis on effect of baseline subretinal fluid on the visual acuity. And it showed that if the subretinal fluid is present at baseline, unlike intraretinal fluid, it did not greatly affect the initial visual acuity and actually had a relatively positive impact on visual outcome once you give anti-VEGF treatment. Fair enough. So you see serous subretinal fluid, you are happier because these are the patients who might show better visual acuity. The CAT study secondary analysis again showed that if there is a persistent subretinal fluid, it did not adversely affect the visual acuity outcomes once you give anti-VEGF treatment. The ancillary study of Excite showed that repeated recurrence of SRF actually may be a problem. So you are happy when you see SRF at baseline and you know it's going to respond, but you honestly do not want it to come back again and again, because if it keeps coming back, it actually may lead to poor visual outcome. Fluid study is a very interesting study which prospectively studied whether the tolerance of some subretinal fluid was good for the eye or not. So what they did, they initially gave Ranibizumab monthly doses until there was, and then there were two arms to follow up the patient. One they called the intensive group, where they did not tolerate any fluid at all. The other was the relaxed group, in which they took care of the intraretinal fluid, but they allowed the subretinal fluid to be persisted and about 200 microns at the foveal center. If it was more than 200, they would treat it. And they found there was no significant difference between the intensive and the relaxed group if you see at 24 months, which again indicates that subretinal fluid, even if little bit of it is present, probably it's good because it's not impacting your visual acuity. However, if you go further into the study, it says, although there was no significant difference, but what happens if you allow subretinal fluid to be present for a long time? There tends to be presence of intraretinal fluid in these eyes, which reappears in the relaxed group at 24 months. It's sounding a bit complex, but the moral of the story is that subretinal fluid itself is not a bad guy, either at presentation or within few months, and little bit of it you can tolerate. But if you allow it to persist and if you allow it to come back again and again, by itself, it may not be harmful, but it has a tendency to lead on to intraretinal fluid, which actually might compromise your visual acuity. So it's not so bad, but still it's not a very good guy. Now I'll show you the example. Now this is the left eye of a patient, and you can see a membrane out here, and you can see it is mostly the subretinal fluid. So Patient receives injections, responds beautifully to anti-VEGF injection because there is no intraretinal spaces. And you see the follow-up over 6 months, the patient has been receiving monthly injections and has maintained a visual acuity of 20/20. This is what we want to do. Now, what if we stop after 3 months? I will show you another example of a later what happens if you stop. Now, from the subretinal fluid, let's move on to sub-RPE fluid, that is the fluid which is under RPE. There are not many studies actually that have investigated the importance of sub-RPE fluid. However, the data does suggest that changes in the sub-RPE space could be indicative that there is a disease recurrence and you may have to pay attention to it. Post hoc analysis of view 1 and 2 studied the effect of PED that was present at baseline and found that if you had a PED present at baseline, it did not really affect the visual acuity per se. Secondary analysis of CAT study again did not find any effect of sub-RPE fluid on the visual acuity outcomes during the time when anti-VEGF was being given. However, in a retrospective study by Lai et al., they found that PEDs were associated with poor visual improvement in the real-world setting. And in another retrospective study, the changes in the sub-RPE space were found to be an important indicator that might predict that AMD is going to recur. So what does it mean? It means that if you see the fluid below RPE, you are not overly concerned because you've got to treat. And with your treatment, it does settle down and the vision is likely to improve. But don't lose sight of this. Keep on monitoring it. If you find the PED is increasing or the sub-RPE space is increasing, maybe you need to be very careful because you really do not want it to progress a lot. And this is what I'm going to show you by an example of our patient. You can see a patient with AMD. So you see the line scan, it is mostly sub-RPE and lesion. He receives treatment, monthly injection, starts responding, and we continue with the monthly injections over a period of, you can see this is 6 months he received, and he is doing well. The visual acuity is maintained, and you can see, he's doing quite fine. This is another example of a patient with type 1 CNV, and this is combined fluorescein ICG, as again said by Professor Atul Kumar. And when we look at it, you see there is a pocket of fluid, and there is this PED, and I don't see hump very clearly, but you can see there is a pocket of streak fluid under the pigment epithelium. So he receives 3 injections, and if you compare it from the baseline, the subretinal fluid is gone, the PD is kind of okay, but there is this streak of fluid, and patient's vision was good. Probably this streak was still an indication to be treated, but after 3 loading doses, since his fovea was attached, the patient was so happy that he did not want any treatment and did not come back to us. When he returned, this is how it was. So this is what I was emphasizing, that this streak fluid on itself will not have an impact on visual acuity because patient is 6/6 part at this point of time. It has done very well for itself. But if you let it be there, you've got to be very careful because this may indicate the disease reactivity or propensity for the disease to recur. And you can see over a period of time, patient has developed intraretinal cyst and subretinal fluid and everything. And now when we start injecting, even after injections, the response is not so good, and neither is his vision improvement so good. So to summarize, any fluid anywhere indicates active disease. It has to be taken seriously. The story continues to evolve. Uh, the resolution of fluid actually correlates to visual benefit. The magnitude may vary. So when you see many studies and you see studies, the visual acuity and the fluid may not correlate, don't get carried away by a short-term follow-up, because fluid today, what happened 24 months later would matter, and it would matter a lot. And again, you will have to see when there is no visual improvement, was the visual acuity too good in the beginning that the 2 lines was not possible to achieve, because there are lots of things which you need to look into. But a more stable central thickness of the retina, which means you have a better control, is definitely being reported to be associated with better visual outcome. So we are all looking at OCT for follow-up, and if we are seeing fluid, we should take it seriously. And even if we don't want to inject it today, don't lose these patients on follow-up, and you have to be, on your guard. With this, once again, I would like to thank AIOS, Namrata. Oh, and Dr. Adrian is here. Hi. And thank you for the opportunity. Namrata, you are muted. Yeah.
Thank you for a very good presentation. There are a few questions on the AIOS YouTube live and questions also on our panel. Rajesh, can you take the questions, please?
Yeah. There's one question regarding it is general kind of a question. Is sunlight toxic or beneficial for development of ARMD?
We're not hearing you well.
Can't hear.
There's an echo which is coming from your.
What is toxic?
Sunlight. Sunlight, is it toxic for? It's a general question. So
Okay.
sunlight, is it toxic for the retina? Does it cause AMD? Yeah.
It's a risk factor for AMD. It comes as one of the risk factors.
So there's another one question. In recurrent wet ARMD after multiple anti-VEGF injections, there is no subretinal fluid. But if we see new vessels in end phase OPT, we have to treat or we can observe for fluid. Yes, Vaishali or Sir, whosoever wants to do that. I think it is from Sir's presentation. Sir, in a recurrent wet ARMD, after multiple anti-VEGF injections, there is no subretinal fluid. But if the vessels are there on the end phase OCT, so should we treat or can we observe the fluid? Can we observe for fluid? Vaishali,
you are muted again. Dr. Atul, you are muted.
Sir, you have to unmute.
Yeah, I did it. So yeah. I've had 2 or 3 cases this year where, despite there was no subretinal fluid, there was presence of large sheet of new vessels in the sub RP space as well as in the pre-RP space. This type 1 neovascularization was there, and I chose not to inject because I thought it's stable. There's no fluid, absence of fluid. But the patient came back within a month.
There is an info from your side. Now it's okay. Now it's okay. Now
he came back within a month with a huge bleed, which I had to surgically intervene in. So I think I'm changing this thing about, if I see huge CNVMs in a patient of AMD, I may still inject without fluid. I may still inject. That's what I requested Professor Vaishali if she could give her expert comments.
Yeah, I agree. We see it most of the times in inflammatory CNVMs because there is a choroiditis scar and then there are underlying vessels. But what is very important is patients generally complain of metamorphopsia. if my patient is symptomatic and I'm seeing these new vessels on OCT angio, I honestly do not care. I would inject. And the second is during the recurrence. Rajesh, there is some problem with your,
Have you?
yeah, you stay
Now
muted.
it's okay. Yeah, now it's okay.
No, it's okay. So during the follow-up, it's important to not always keep on injecting because the mature vessels on OCT angio will persist, but you look at the borders. Any hairpin loop, you look at the density. If there is an increasing density, or like Professor Atul said, you may have type 1, type 2, but you may have type 3, where you will see a linear line which is hyper-reflective
wrap.
going between the two layers wrap. So these are some of the very important indicators that this is the membrane which is going to get the fluid over a period of time. I don't think there are clear-cut guidelines whether to inject or not to inject, but I would talk to my patient and, if patient is symptomatic and understands, I would inject.
Can I offer a couple of comments here?
Yeah, sure.
Yeah, so I think I'd like to answer this in two parts. One, there's been this excellent publication from Dr. Rosenfeld and the Baskin group on intermediate AMD. And this slow, silent, quiescent growth of vessels, which predates the appearance of fluid and the subretinal compartment specifically. So what they've been able to show is that nobody's really been able to put the finger on that trigger as to when this growth of this quiescent growth of vessels under the RP will translate into subretinal fluid, and then that becomes symptomatic. On the other hand, you have this other treatment regimen called treat and extend, which is coming in, where people are treating when the macula is flat. So as a way of, pushing back the patient's visit. So if you look at both of these together, it probably suggests that sometimes when you're treating extending, you might be treating when there might be this little bit of quiescent membrane or neovascularization under that RP. So as our experience with OCT angiography increases, and Dr. Vishali rightly mentioned, that it's not those pure vessels which you need to be looking at, but these little neovascular sprouts, fine branching ones, which you need to pay attention to. These may be indicators of or biomarkers of impending subretinal fluid. And perhaps we do not have as much, but perhaps experience with swept source angiography. I think Professor Atul has a lot of experience there and has been one of the pioneers of swept source OCT angiography in the country. Greater experience with that might help us understand when these triggers will happen and when subretinal fluid will come, and that may help us proactively treat this before it happens.
I think Adrian wants to add, yeah.
Please, Dr.
Hi, everyone, and thank you for inviting me. It's a great pleasure for me to join this great group on the panel. Thank you. It's a very, very important question, right? Do we treat based on OCT angiography flow alone, or do we have to wait for fluid? And I was just going to talk about treat and extend because, as Anand says, very often the goal of treat and extend is to proactively treat when the macula is dry. So you would expect to still see flow in the new vessel complex. We would not expect the new vessels to disappear. So in that situation, you would continue to extend, but still expect to see flow on the OCTA despite not having any fluid. However, I have patients where the neovascularization flow is increasing despite no fluid. I don't extend. So let's say he's on an 8-weekly regimen and his vision is stable, there is no fluid, but I see an increase in the flow pattern on the OCTA. That's very useful to me because if I were to extend it to 12 weeks, I might get a breakthrough, and I tell patients I then bring you back all the way down to 4 weekly treatments again from square one. So that's one issue. I think we have to treat the OCTA with caution because we are only seeing flow and not the consequences of flow. Of course, we typically see this in branching vascular network in a polypoidal situation where there is no flow, maybe no leakage at all, or activity from the branching vascular network. So sometimes we might end up over-treating if we base our judgment only on flow on the OCTA. So I would still caution not to treat it on that basis. But as Vishali has said, if the patient is symptomatic or visual acuity worsens, I would base my treatment judgment on that basis.
And I think it's also very important that when you are repeating the angio-OCT, your slab, your placement and all, when you are comparing, it's very important that you are precisely comparing what you saw before.
Absolutely.
So, yeah.
And of course, I think the B-scan mode has been a great addition.
Absolutely.
In my mind. With the on-fast, you are looking only at the pattern. But we are very, very sure once you have the B-scan mode on that there is actual red blood corpuscles in those patterns.
It was a great discussion, and now it is my like the next speaker, Dr. Edwin Pope. Dr. Edwin Pope is going to speak on manufacturing anti-VEGF, current clinical evidence.
Thank you very much.
There is some issue with the audio, probably. Yeah.
I'm just trying to sort that out. It's gone now.
Yeah.
Oh, that's much better. But thank you very much, Dr. Sharma, and thank you everyone. The AIOS is a wonderful organization, and we have such close and fond memories of AIOS meetings. I wish that soon we will have an opportunity to meet in person once again. And I would like to now share my screen for my talk. Can you see my slides?
The echo is still there. Yes, we can see your slides.
Okay, thank you. Over the next few minutes, I would like to discuss Brolucizumab. As you know, there has been a lot of interest surrounding Brolucizumab. Soon, India will have this drug available. It was approved in the US by the FDA in October of 2019. And since then, we've seen the drug available in Europe, in Japan, Australia, and many parts of the world. So it is important for us to understand what this drug is and what more it brings to our armamentarium of treatments of wet AMD. You have heard excellent talks from Professor Atul as well as Professor Vishali on the approaches that we now have largely agreed on in treating neovascular AMD. What we do need is something new, stronger, and longer acting. And I believe that Brolucizumab gives us an opportunity for this. These are my financial disclosures. And before I start, there is a disclaimer from Novartis. So for today, I would like to talk about three aspects. The first is, what are the unmet needs and challenges that we face in the care of neovascular AMD patients? I will then introduce what is the newest anti-VEGF treatment that we have available, which is Brolucizumab or Beovu, and study in detail the clinical evidence from the pivotal trials called HAWK and HARRIER. Now, we all know that AMD is a problem that is here to stay. If you asked me 20 years ago how bad was this problem with AMD, I would say it was not as bad as diabetic retinopathy. But I think in many parts of the world, certainly in Singapore and Southeast Asia, this is a growing problem. And AMD has overtaken diabetic retinopathy as the major cause of blindness in people over 65 years old. And just look at the burden. The projected numbers already in 2020 are 200 million. And this is really going to increase exponentially in the coming years. Of course, I think if you've been in practice, in retinal practice for long enough, you would have appreciated the leaps that have been made, the great steps that have been achieved in the management of AMD. Remember that as early as the 1980s, there was really no disease, no treatment for this horrible disease, right? Vision loss because of no treatment was the rule. Even with thermal laser, for subfoveal choroidal neovascularization, you are going to lose 3 to 6 lines, but you would avoid 6 lines or more loss of vision. Now, I was fortunate to be involved when photodynamic therapy with verteporfin was made available in the early 2000s. Even then, it was like cutting off one finger to save the hand. And we did not have any satisfactory treatment that could improve vision until the arrival and introduction of ranibizumab, the first anti-VEGF therapy. Well, I would say not the first, but probably the most effective anti-VEGF therapy at that time compared to Macugen. Before that, if you recall, we had a short period, 2004 onwards, where we had pegaptinib or Macugen, which had a very similar result to photodynamic therapy. Now here we are at 2020 still talking about the evolving spectrum, because I think we are far from achieving perfection. We are nowhere near that. And we really have to look at how we can improve and optimize vision further. In particular, we are now faced with the burden of frequent treatments. These patients who have been successfully treated and have their vision improved or even restored continue to require long-term vision, long-term therapy. Overall, you can see worldwide, in many parts of the world, and I'm sure this is true in India as well, that the incidence of blindness has been significantly reduced with the introduction of anti-VEGF therapy. So we are already talking about a fantastic revolution in our times. I think many of us would not have dreamt when we started out in our careers of something as marvelous as the anti-VEGF revolution. Nevertheless, we should not rest on our laurels. Look at the undertreatment in the real world. With the randomized clinical trials, you get decent results, plus 10, plus 11 letters. But in the real world, this is really not so. Even in countries with very good reimbursement systems and good social networks, for example, in Australia, you're looking at a plus 5 letter rather than a plus 10 letter gain in the real world. And in some countries, even in developed countries in the West, from the Aura study, for example, really the results were quite disappointing. Luminous, for example, showed that over 70% of patients currently are undertreated in the first year of therapy. We know how important it is to be aggressive in introducing treatment in the first year. On average, you would require at least 7 or 8 injections of any anti-VEGF to achieve the optimal results we see in the pivotal trials such as Marina and Anchor. Now, there are several barriers that can lead to this undertreatment. The most important, I think, is treatment burden. In many countries, like in Singapore, the drug is not reimbursed, and so patients find it financially impossible to sustain long-term, frequent, regular, expensive treatments. Then, of course, the system itself can be stressed. There are too many patients who require our care. Then, of course, the patients at their age group may need help at home as well as in coming to the clinics. And last but not least, education. So I would say that the scorecard for how we are doing currently with our management of neovascular AMD is mixed. Yes, we have done well in terms of proven efficacy. We have done well in reducing blindness from neovascular AMD. So all that's well and good. But I'm sure you will agree with me that there are many challenges that are still yet to be overcome. For example, maintaining long-term efficacy, reducing frequency of treatment and monitoring, that's a real challenge for my patients. Reducing burden on patients, and I'm not just talking about financial burdens, plus their caregivers as well as healthcare resources. So I think there is a lot more work to be done as a community of scientists. But let me now introduce what we have at the moment. The newest anti-VEGF, which has been approved in many countries, is Brolucizumab. Now, what is Brolucizumab? It is the most clinically advanced single-chain antibody fragment currently available and designed specifically for ophthalmic use. Now, this is the full-length antibody. I think most of you are familiar with both the variable as well as the fixed domain chains, so the 2FAB as well as the FC portion of the full-length antibody. And typically we would have seen this with bevacizumab. Now, the ends of the variable fragments, both heavy and light chains, are marked by these small, tiny regions known as CDRs. Now, the CDRs are called complementarity determining regions. These are the exact antigen-antibody binding sites. The rest of it is to stabilize and to support these binding sites. But it is these CDRs that are responsible for binding to the antigen. So in this case, we are talking about VEGF, right? So these are the VEGF binding sites. Now, if we were to isolate just the CDRs of the entire antibody, this is where the VEGF would be bound, but obviously the CDRs cannot exist on its own. So if you couple that and graft it on a human single chain FV scaffold, you then end up with the final very small molecule. Note that there are only the CDR regions plus the variable region. There is no FC portion at all for this drug. And that's how we end up with brolucizumab. It is only 26 kilodaltons in molecular weight. This is a nice comparison with what we are currently using, aflibercept, which is a fusion protein, here about 100 kilodaltons. Ranibizumab we are also very familiar with, which is the FAB fragment, and it's clearly about double the size in terms of molecular weight compared to brolucizumab. In terms of clinical dose, aflibercept is 2 milligrams, ranibizumab a standard dose of 0.5 milligrams, and brolucizumab is a whopping 6 milligrams. Now, in terms of relative number of molecules, because of the very small size and molecular weight of brolucizumab, we are able to pack in 12 times the number of molecules per injection compared to a similar injection with aflibercept. So this is clearly an advantage. This engineering is really to do a few things. You achieve more drug in a single injection. You have then potent inhibition of VEGF-A. In fact, the affinity measured through a coefficient constant is a higher affinity for VEGF with brolucizumab compared to aflibercept. And because of its small size, rapid and effective penetration of the retina into the choroid and very rapid clearance from the systemic circulation. The last is important because these are elderly patients who might have coexisting cardiovascular morbidity, and a rapid systemic clearance will greatly reduce the risk of thromboembolic events or APTC events. Now, Hawk and Harrier are important because they were the phase 3 pivotal studies for brolucizumab in neovascular AMD. Hawk was a 2-year study randomized into 3 arms of treatment. You see these as 3 milligrams and 6 milligrams of brolucizumab, almost 360 patients in each arm. And the comparator or control was aflibercept 2 milligrams, also 360 patients. Harrier was only 2 arms, brolucizumab 6 milligrams versus aflibercept 2 milligrams. And the primary endpoint was a non-inferiority of BCVA change at week 48. Now, this was a multi-center trial. Many parts of the world participated, including Singapore. Hawk were really global sites, especially the US and Japan, Australia and New Zealand. And the rest of Asia, Russia and Europe were in the Harrier study. But the design was similar. If you look at Hawk and Harrier, the comparator was aflibercept. These patients all received the first 3 loading doses at 4 weekly intervals, followed by 8 weekly subsequent fixed treatments. So this is as per label. Now, with brolucizumab, either 3 or 6 milligram, depending on which study we're talking about, the 12-week treatment was, of course, omitted. There is no treatment after the first 3 loading doses. 8 weeks after, at week 16, this is a very important point in the study. It is for disease activity assessment. And thereafter, you see disease activity assessments at week 20, 32, 44, 56, and so on. Now, why is 16 important? Because at week 16, disease activity was important in determining whether patients were eligible to go on Q12 or they needed to go on a more frequent Q8 regimen. So for example, if the patient was deemed not to have disease activity at week 16, he would then be placed on a week 12 regimen, such as here, 20, 32, and 44. And at each subsequent disease activity point, if there was disease activity, the patient would then drop back to a Q8 regimen and would stay on a Q8. There was no chance in this study for him to go back onto Q12. So this was actually quite a high bar for patients to remain on a Q12 throughout the study, and you will see later why I say that. Now, the primary endpoint, as I mentioned, was non-inferiority between the treatment regimen, Brolucizumab, either 3 or 6 milligram, compared to 2 milligrams of aflibercept at week 48. And the non-inferiority margin was set at 4 letters. This is in keeping with many other studies. I won't go through all the secondary endpoints, but I will show you the results. This, as mentioned, was a disease activity assessment criteria, very similar to what we use in clinical practice. Visual acuity decrease, as well as fluid, new fluid, especially intraretinal cysts, were all important markers of disease activity. Remember that all these were all based on the discretion of the treating physician. Now let's look at the primary results. The primary endpoint was met at week 48, meaning that Brolucizumab in both doses was non-inferior in achieving visual acuity gains and maintenance compared to aflibercept of 2 milligram. Here you see the two curves, the 3 lines overlapping. And this continued right through to week 96, which was the end of the study. So for both HAWK, which is the top, and Harrier, there was non-inferiority between Brolucizumab and aflibercept. So the primary endpoint was met. Now, why do we say that Brolucizumab is a longer acting anti-VEGF, at least compared to aflibercept? Well, for one, over 50% of Brolucizumab 6 milligram patients could move immediately after loading phase to a week 12 dose interval. This is really significant. 56% of 6 milligram and 51% of 6 milligram in HAWK and Harrier respectively could move immediately from 4 weeks to 12 weeks. Many people ask me, what is the big deal about 12 weeks? It is a big deal because when we do treat and extend with either aflibercept or ranibizumab, only 20 to 25% of patients are ever able to maintain their intervals at Q12. And that is after a long period of time. Most times we can only move up to Q12 at the end of the first year. Here, at week 16 onwards, the patient is put on a Q12 treatment interval. In terms of predictability, this was very good. 82% in HAWK, 75% in Harrier of patients who were on Q12 at week 48 remained on Q12 for the rest of the study in the second year. In other words, once you are able to continue in the first year with Q12, you're likely to only require 4 treatments a year subsequently. Next, I want to show you some evidence that Brolucizumab is a stronger anti-VEGF than aflibercept, at least in this study. Here you clearly see that the reduction in central subfield thickness was very impressive with Brolucizumab, compared to aflibercept, where in aflibercept you still see this seesaw pattern, meaning that fluid starts to come back towards the end of the 7 or 8 weeks in between aflibercept injections. Remember that over 50% of the patients with Brolucizumab were on Q12 treatment. So this is, I think, a significant improvement over aflibercept in terms of control of fluid. And indeed, when we look at disease activity as a whole, and we looked at disease activity through presence of fluid anywhere, new hemorrhage, growth of choroidal neovascularization, the typical criteria, there is a clear advantage and statistical benefit of Brolucizumab over aflibercept. Here you see in both studies a consistent picture. A 30% lower rate higher rate of no disease activity achieved with Brolucizumab. What if we break this down into compartments of fluid? You heard from Professor Vishali how important fluid is and the relative importance of the different compartments. The most important compartments obviously are the intraretinal and subretinal fluid. Fewer patients on Brolucizumab had intraretinal and subretinal fluid for all these weak points, 16, 48, and 96, when compared to aflibercept. And these are impressive figures, 35%, 36%, 40% reduction in the presence of fluid when you use Brolucizumab. In other words, there is consistent and clear evidence of greater drying impact of Brolucizumab over aflibercept. And this extended to sub-RPE fluid as well, the same proportions, about 30 to 40% stronger action in terms of drying fluid in the sub-RPE space. And this is not surprising because of the small molecular size. We expect that this drug gets to the deepest layers of disease pathology very quickly. So overall, you see that more patients achieved complete fluid resolution. After all, this is what we are trying to achieve. We don't want to see any fluid as much as possible, since you heard from Professor Vishali that all fluid in the macula is pathological. Similarly, you see in Harrier the same results. More patients could achieve complete fluid resolution with Brolucizumab compared with aflibercept, and all these are highly statistically significant. You also heard about consistency and the control of fluctuation. It's not so much only reducing or eliminating fluid. We do not want any fluctuation as far as possible, because we know that the more fluctuation there is, the worse the final visual outcome. Here you have good evidence of how Brolucizumab can control and minimize fluctuation. To achieve 3 or more consecutive fluid-free visits is not easy, even with the best treatment that we currently have. But here with Brolucizumab, you find that the incidence of at least 3 consecutive fluid-free visits was significantly greater with Brolucizumab. Here you see about 24% greater chance in HAWK and 43% increase of at least 3 consecutive fluid-free visits. All these point to greater durability and more consistency of action. This is a typical example of a patient who had received 6 milligrams, 3 initial loading doses, at week 16 found not to have disease activity, therefore put on a Q12 treatment regimen. And within the first 16 weeks, the macula is already dry. Not only is subretinal fluid eliminated, but sub-RPE fluid is also greatly reduced, if not totally eliminated. And by week 48, the macula is flat and dry. Up to 96 weeks, it is well maintained. So these patients maintain very stable vision with no recurrences and no fluctuation. I think the last bit which I want to discuss and maybe spend a bit of time on is safety. For any new drug to be useful and widely used in the community, it has to exhibit well tolerated in terms of safety. Now, if you look at HAWK and Harrier, the results were good. In 3 milligram, in a 6 milligram doses compared to aflibercept, there was no statistical or significant difference in adverse events, either in serious adverse events or even non-ocular thromboembolic events. Here you see with 6 milligrams, it was 2.8% in HAWK, aflibercept was 4.4%, not statistically significant. In the Harrier, so with 6 milligrams, it was 3.2% versus 3.8% with aflibercept. This is for the APTC event. So there was no signal of systemic serious adverse events. But in terms of ocular safety profile, there has been quite a lot of attention paid on inflammation. Here you see with the original HAWK and Harrier data, we had 4.7 and 5.8% of intraocular inflammation in HAWK and 3% of inflammation in Harrier when we use Brolucizumab. And this was higher than the aflibercept 0.6, 1.1, although these were not statistically significant. And also retinal artery occlusion was a low 1.1% in HAWK and 0.5% in Harrier. And there was no significant difference in terms of endophthalmitis. As you know, when the drug was first approved in the US, post-marketing, there were reports, isolated case reports, of patients who developed severe inflammation, including occlusive vasculitis. And some of these patients who developed occlusive vasculitis actually lost vision and did not recover. So obviously this was a great concern for all treating physicians, not just in the US and worldwide. And so there was a review of all patients in both Hawk and Harrier to relook whether the inflammatory rates were correct. And indeed, they were not different. You see that after rounding up, it was 4% of intraocular inflammation with Brolucizumab compared to 1% with aflibercept. In terms of retinal artery occlusion, it was 1% still, and endophthalmitis, it was 1%. Nonetheless, I think there are unanswered questions about the etiology and who are at risk for this inflammation. And I think it will be useful later when we discuss to also seek the opinion of the other panelists, and I know many of you are very experienced with inflammatory eye disease, for your thoughts about what could be causing these inflammations and how we can identify early and perhaps treat them. So to summarize, we now have Brolucizumab, the newest anti-VEGF agent, which has shown to be stronger and longer acting than aflibercept. This goes a long way in helping us meet some of the unmet needs, such as treatment burden. So we have this potent novel drug. And phase 3 studies like Hawk and Harrier have now confirmed that in terms of visual acuity, Brolucizumab was non-inferior to aflibercept, but more importantly, it had superior drying effect, anatomically better than aflibercept in terms of both intraretinal, subretinal, as well as sub-RPE fluid and overall disease activity. Coupled with this, we see less fluctuation in the central subfield thickness, which is really important for long-term maintenance of the photoreceptors. Last but not least, we have an opportunity now to have a longer acting drug. Successful completion to a Q12 interval at week 48 was possible in over 50% of patients. And once you could achieve that at year 1, there was a high probability that you would be able to continue on a Q12 interval up to week 96. And overall, the safety profile was comparable to that of aflibercept. There was no statistically significant increase in ocular or systemic adverse events. So I'm really excited about how we can incorporate Brolucizumab in our current armamentarium of treating neovascular AMD, and I'm confident that this drug will be a very useful addition to what we have. Once again, thank you very much, and thank you to the AIOS for allowing me to speak at this forum.
Thank you, Dr. Ko, for your excellent talk and coverage of the new molecule. I'm sure the panelists will have questions for Dr. Ko.
Thank you.
Yeah, thank you, Dr.
Anand,
that was wonderful.
Dr.
And
Mishra, Dr. Dogra, sir, Dr. Atul, sir.
See, the ASS, American Society of Retina Specialists, they had issued a warning about the occlusive retinal vasculitis. What do you think? It's not much significance, or?
No, I think it is. It is significant because of the unknowns. Actually, it is because we don't fully understand which are the patients who get it, who are at risk, and what to do about it if they do develop occlusive vasculitis. So it's important that I think Novartis has been very forthcoming and has not swept this issue under the carpet. In fact, they had taken the initiative to convene a global committee to relook every single case in the 1,000 patients that they treated in Hawk and Harrier. It was a very difficult task, which they completed within 6 weeks, which was, I think, compliments to them. But I have a few sort of my own thoughts in this. Yes, it is serious, and yes, it is potentially devastating, but the perspective has to be correct. Firstly, it is a good drug. As far as the effect on AMD is concerned, I think it is quite undisputed that it is a very effective drug.
Long acting.
But we have to be careful who we use it on and how we then detect inflammation early. In other words, those with pre-existing uveitis should not be given the drug. And as you know, many medical retinal specialists perhaps are not experts at inflammation. You know, they may not be able to diagnose accurately pre-existing uveitis, and that's where people like Professor Vishali and colleagues will be very important in teaching us how to identify these patients, because I think we should not use this drug if they have pre-existing inflammation. And then the second is all those with occlusive vasculitis had other signs of intraocular inflammation. So if we can catch anterior chamber activity, if we can catch early deep vitreous activity, maybe we can stop it, or maybe we can avert the full-blown occlusive vasculitis. But I think we have to get the perspective right. Occlusive vasculitis occurs in less than 1%. If you think about it, aflibercept can cause, well, stroke and heart attack is associated with aflibercept and ranibizumab in 3 to 4% anyway.
Right.
Can I add?
Yes.
I think listening to all this, there are two things which come to my mind. First is the incidence of occlusive vasculitis was not so much in the trial as compared to the real world.
Yes.
The reason could be that when we have a trial, we have a very strict criteria for washout of any other drugs that the patient might have received. And, you know, we just make sure that the eye is ready to receive the treatment. Either it is treatment naive or it has undergone. When we come to real world and we have a new product with us, we are so excited that something is not working, that after 6 weeks, 8 weeks, you just inject another one. So it could be just a possibility of interaction.
Correct.
The second is not only the uveitis, the AMD itself is a kind of inflammatory disease like diabetic retinopathy. So it may be a good idea. And now listening to you, I'm tempted to do it when for trial, we never fortunately had this problem, but when we get it in the real world, to look at the laser flare meter.
Yeah.
Reading. You know, I would do LFN and I will do the grading of the vitreous cells on my swept source OCT using the classification. So as to differentiate the inflammatory variety of AMD or inflammation induced by the previous injections, and take it forward from there so that when I inject it in the eye, there is zero inflammation. That might help and that might answer some of the your questions that we have.
Excellent. I agree entirely. And I think one additional step that I would urge everyone to consider is to have a baseline wide field fluorescein angiogram.
Absolutely.
I have few sort of observation as well as comments to offer here. I think what Dr. Shali said is very true, but the laser flare meter, as you know, would be available hardly with very, very few people. And this drug is used, everywhere. So that would be a little bit of a problem. The issue is once we know this drug is effective, it is longer acting. One of the issue which I think at least whatever we read about this vasculitis cases reported is where both eyes were injected simultaneously. I think we'll have to be very careful not to inject both eyes, and also not to inject in a one-eyed patient, because in the beginning, because you see, once there is an alarm and such a situation, then you get into a very, very different situation. Of course, I think they need to study these cases much more where it happened, that really go into the entire detail, that what really was different in them. which caused this kind of a vasculitis. So that also need to be looked at very thoroughly, if at all, because the problem is now retrospectively looking at those patients may not be really feasible, but there must be something. As Dr. Adrian, you mentioned about the inflammation part. So we are not sure, and we'll never know that whether there was an inflammation pre-existing somewhat in these cases. So there are so many, but this is a wonderful drug, no doubt. It kind of dries the retina totally, as well as it is longer acting. But this has raised what you already called sort of the red flag for everyone across.
I think this is a question which has been asked across all platforms, on Facebook, on YouTube, as well as on our platform, our web page, by everybody, that, what about ocular inflammation and what about occlusive vasculitis. So I think it was very important to clear that part.
Yeah.
Steroids may help, Adrian. Once you
Yes.
have it, I would give steroids if it happens
Definitely.
to my patient.
And aggressively too, I think very aggressive.
IV
Yes.
methadone, yeah.
Yes,
I would do that.
and obviously I think we would recommend not to use it subsequently. Go back to the original treatment regimens. I have some thoughts about this issue, if I may. One is that when we first introduce a drug in the real world, we are almost talking exclusively about switches. So these are patients who have received many injections of everything, right? So I think that may play a role in sensitizing these patients to an inflammatory process. The second is it may not be an inherent drug problem. And I had asked specifically for Novartis to study the manufacturing process. If you remember recently, there was Orgedex with the not the drug, it was the vehicle, right? Introduction of silicone. So there is a possibility that it is not the drug itself, it may be the manufacturing that resulted in introduction of impurity, something like that. And therefore, I'm very keen to look at the rates of inflammation in Europe and in Japan, because if they are made in a different place or a different plant or facility, and we don't see the same inflammation, that may be the answer. It may be very localized to a US-based problem. That's another thought. The third is there a relationship between the small size of molecule and inflammation, right? Because we see, for example, with the failed Abicipar, there was a high inflammation rate of about 18%, and that was one of the reasons it did not proceed with an FDA approval. So is there something inherent in a small size molecule that makes it more antigenic? That will be interesting question also with faricimab by Roche, because it is also a small molecule. Do you have any thoughts about what could be the underlying mechanism for inflammation, assuming that these patients did not have pre-existing uveitis? Let's say they were just normal, regular neovascular AMD. What could be the reasons why they developed this inflammation?
So I just want to substantiate and add a corollary to what Dr. Adrian said. Going beyond the small size, because actually this size is not very different from what Macugen was. Macugen is also about 29 kilodaltons and a small pegylated aptamer. But my thoughts on this aspect is that this is the only one where you have a synthetic fragment coming on, and you have these CDRs, the complementarity derived regions, being implanted here. And because it's small, you're also giving a very large number. So while in both aflibercept and ranibizumab, polarity is 0.5 and 1, here it is 10 times more. So you're giving 10 times more drug, and you're just reaching non-inferiority. Actually, if you go to see the carrier component of the two, 6 milligram was almost consistently under the graph of the 2 milligram aflibercept. Okay, and you're giving a lot of drug, and in over 1,000 patients, suddenly you have this 4% incidence of occlusive vasculitis. So could it be that synthetic A, or could it be, like you mentioned, some excipient that's going along, and perhaps the whole process needs to be a little more refined, to knock off that? And could it be, the amount of drug which you are pumping in, 10 times more in terms of the active moiety? It could be any one of these.
Ajay, would you like to give
or it could simply be that you already have some receptors blocked because you are not giving it in the treatment naive patient in the real world. And when you put in so much concentration, it just knocks off the remaining receptor and there is occlusion. I mean, it's just a thought. I don't know, but that could be another possibility.
Dr. Rajiv, would you like to
say? I think I agree with all the panelists. We really don't know the answer why this happens. And I think one of the good initiatives which Novartis has taken is creating a think tank. They have created a think tank who are looking into all these things, and good thing is it is publicly available, the findings, it is in the website where you can go and see, and they are looking at all these angles. So I think there is a sincere thinking about this thought, like, can we identify patients who may develop inflammation? Or as Dr. Adrian rightly said, is it these patients who had multiple injections? And there are another studies where they are trying to use treatment naive patients and trying to find out whether they will have less. So I think next few months in India, probably it will come in December. And I think before December, we should get some answer about these questions.
Thanks, Rajiv.
Just for my knowledge, was any Indian site involved in the study?
No. So Hawk and Harrier were
not in this. But we have been involved in other trials with Brolucizumab, and there has, touch would not been any problem.
Yeah. Can I just add also that actually when the drug is available in India, it is a good opportunity for the Indian retinal community to form a local safety expert council. We are doing this in Singapore because when we expect it in September, we want to first understand and study the pattern of the inflammation and other adverse events, not just inflammation, in local patients. As you rightly say, we don't have that many Singapore patients in the trial. We have a few. And in your case, it will be important to understand how this drug interacts and also works in an Indian population. So we try not to allow the drug to be too widely used indiscriminately. Our local committee will then set out guidelines as to the requirements, what we need to do pre-op, what to document, when to call the patient back for follow-up, and have quite a close surveillance initially, at least for the first 6 months, before we allow that to roll out to general ophthalmologists. I think that would be the responsible way to protect our patients.
I think that's a good idea.
Excellent. Very good idea. Actually, AIOC, AIOS and VRSI can take an initiative. And
I think
probably,
Rajiv, all the major institutes are already here.
Yes.
Colonel Mishra, are you there? From RR and then PGI and then
Yes.
Yes, we are all here, ma'am. In fact, we are taking up this as a research project. Whenever this is launched, that we are taking as a medical research project from the armed forces about the safety profile of this drug.
So I think all of you can just join in together, and maybe it's a good exercise to do. And I hope Novartis is listening and they are aware of this. And I'm sure
they should create a safety council.
Yeah, at least they should form a safety council like Dr. Ko has advised, and like Dr. Atul Kumar sir is also saying. I'm sure all of us are on the same page, and this is something which has come good out of it. So we were being watched by almost 3,000 people across YouTube, Facebook, and on our landing page. And there were a lot of international viewers. The feedback that I am getting, a lot of students, both Dr. Vaishali's, Dr. Dogra sirs, and Dr. Atul Kumar sirs, who have watched this and have given really good comments. And if there is anything further to be discussed, we can take up. Otherwise, we can conclude the session. One last remark from everyone, Dr. Atul Kumar sir.
Yes, I just want to say that this was a very well organized, very well thought of webinar or a symposium, as you say, with AIOS having involved itself. Professor Namrata is herself very academic, and she likes to pursue academic interests. So thanks to her being totally in an academic institution, she's more interested in such like symposia and webinars. And we also thank Novartis for having accepted and keenly followed this up. And we had guest speakers from India, and of course, Dr. Adrian Ko is a worldwide known figure in retina, and having him here as a guest speaker was really a treat for all the Indians and the students to watch him, hear him, and also take the latest back to their rooms. Which, because in this COVID era, it's difficult to get knowledge on a personal basis. It's better that we get knowledge at such times from people who are eminent personalities in the world, like Dr. Adrian Ko. So I think it's a very well organized by AIOS, and much thanks to Professor Namrata Sharma and Professor Rajesh Sinha for having organized this meeting.
Thank you, sir. Anand, would you like to say something?
Thank you. I think this was a wonderful effort. Thank you again, Professor Atul, Dr. Adrian, to taking time out and joining us. Dr. Adrian is such an old good friend of AIOS, Retina Society of India, and all of us. We value his contributions too much, and we know he's such a major figure in Asia Pacific sector of retinal sciences. And thank you again to all the panelists, Professor Dogra, Professor Vishali Gupta, Rajiv, a good friend from across the city. It's wonderful to have this effort. And I think this is very important, like Professor Atul and Dr. Namrata said, that it's important to have a safety committee. And also from Novartis side, please make efforts to have a strong reporting system. So that I think is very important. The moment we started, we should have a very open, transparent, and strong reporting system, so that data is collected, and we can look to Dr. Adrian Ko also to give us inputs and feedbacks on how things are in Singapore too. So thank you again. It's been a wonderful experience being part of this.
Dr. Dogra sir, would you like to say something?
We had excellent symposium with the best talks, I must say, from Professor Atul, Dr. Vishali, as well as from Engine. And I think everything was covered very well, and especially about a drug which is just coming to us, and a lot of concerns has been raised. I think every aspect has been very well discussed, and I think what need to be done is also discussed. And so I'm really thankful to Dr. Namrata and Dr. Rajesh for putting up this symposium, which is timely. And I think we definitely need to discuss, and that is what has been done today. So thank you very much, everybody here in the panel, as well as all the speakers.
Vishali, would you like to say something?
Yeah, thank you very much. As echoed by everybody, I would just say that I would go with a product where the company is honest about the side effects, and we are looking forward to it, then going with a product where everybody says 100% safe and you're not sure about it. I really value Novartis for its honesty, and I'm sure we will sort out these initial hiccups. Thank you, Namrata. Thank you, Rajesh.
Thank you, Rajiv. And Rajiv, would you like to comment on this?
It was really a great webinar. Thanks, AIOC. Thanks, Dr. Namrata and Dr. Rajesh for organizing it. It was a very good mix. I would say we had the great stalwart, Dr. Atul Kumar, who had a wealth of experience, who spoke very holistically from an unmet need in AMD, which especially in our country. And I think each word or each slide was a pearl of wisdom. Okay, it really was a very important thing. We had another component, Dr. Vaishali, who, though we always remember her for inflammation, and AMD has an inflammatory component. So definitely her talk. And then we had the expert, Dr. Adrian Ko, giving us the nuances, the newer trials and the newer stuff. Definitely for all budding ophthalmologists and even the retina specialists, this would be a very valuable webinar. Thank you. Thanks for having me part of it.
Dr. Mishra, and then we'll have the final word from Dr. Ko.
Thank you very much, ma'am. I think it was a very good opportunity for all of us, including the representation of armed forces coming into at this international level. It's very important in the present scenario when the things are totally different, what we have in the normal circumstances. How do we approach our patients who are actually very scared to come to the hospital, give them confidence that yes, they are safe and they can be safely handled by our experts. Calling them and talking to them is very important. What we follow up in our armed forces setup is that we have dedicated team and we have a complete data of these patients. We track our patients, we call them up, and we follow them up very diligently and treat them and give them a lot of confidence that yes, they are not going to lose their vision. And as far as our ex-servicemen are concerned, we have a very good system of online sanction and giving them sanction to go to their respective empaneled hospitals. As far as this new drug is concerned, I am sure that all the important centers are going to take up this challenge and do some research work on that. What is very important, what Madam said, that we should be honest in our reporting. Not only the company should be honest, but the treating physician should also be honest, that any incidents of these kinds should be reported, and we should all sit together and sort it out and come to a conclusion that it should be safe for our all patients and can be safely used for our future. Thank you, ma'am.
Dr. Ko, finally, and you then conclude.
Thank you. It's always such a wonderful privilege and honor to be among friends. And, all of you have been my friends for so many years. And I greatly respect all of you. I've learned so much from this symposium. And it is this, exchange of ideas among friends that I think will help us improve in our delivery of care to our patients. I think we must admit that, things have come such a long way. Many of you would share with me the frustrations that we used to have with the earlier treatments. And of course, it is not perfect now, but we have such a wonderful opportunity to give our patients hope. And it is this hope that will drive us to study more on AMD and its aspects and to improve what we are currently giving to our patients. We have learned so much about the role of fluid, how we should manage each particular aspect, what treatment regimens to use, not just new drugs. And so I think we should continue to work together in a community. I will be very, very interested to learn your experiences with Brolucizumab, as I will be happy to share mine. And I think together we can make a much more meaningful contribution to our patients. And ultimately, they will be the winners in this whole affair. Thank you.
Thank you so much, everybody, all the speakers, for being with us today for this great webinar. You know what it is going to involve all the centers in the safety profile of the new drug that they are launching. And I would like to thank Dr. Rajesh Sen, also co-moderator with me. And we would like to thank the AIOS team, the audiovisual team, especially Mr. Sunil and Mr. Kripal. And of course, we would like to thank Novartis, especially Mr. Anupam Khare, for taking this forward. So thank you, everybody. Thanks, Atal.
Thank you.
A big thanks to all the speakers and the panelists for sparing their time. Thank you very much and good night.
Thank you. Good night.